Dr. Meredith Vanstone is an associate professor in the Department of Family Medicine here at McMaster University. She holds a Canada Research Chair in Ethical Complexities in Primary Care, and of course, this is a topic that fits well into that framework. Her research as a qualitative researcher has a particular focus on pregnancy and reproduction, and she's going to be talking today about an area that is going to flow very nicely from the last presentation that you just heard. It is going to be about the decision-making around use of cannabis during pregnancy and lactation. So thank you very much, Dr. Vanstone.
Hi everybody. Thank you for having me. So I'm going to focus on some of the decision-making parts of why and how people decide to use cannabis while they're pregnant or while they're lactating. So just disclosures, this research was funded by CIHR and also by the Department of Family Medicine. Most of the collaborators don't have any conflict of interest, but we did have one research coordinator who had some previous work and also some side work working for a cannabis producer and clinics. I want to acknowledge all the collaborators. We have a number of clinicians, midwives, family doctors, and obstetricians who participated in this research, and also wanted to thank our student research assistants, Anu, Shipra, and Alex. So I'm going to talk today about an ongoing program of research. I'm going to outline a key finding from 2 systematic reviews that we did, and then I'm going to talk in more depth about some of the findings from our qualitative interviews with pregnant and lactating people. I know the title says clinicians, and Alex has put together a wonderful poster of the clinician perspectives that will be outside in the hall. This is buzzing. Does that matter? Maybe it's losing batteries? Okay. I guess we'll find out. Okay, thank you. So I think like many of you who are interested in the gestational impacts of cannabis, impacts of gestational cannabis use, this really came about around the legalization of cannabis in 2018. We know from other jurisdictions where cannabis is legal that typically after legalization, use in the general population increases, in part because it's more available, in part because stigma goes down, and in part because there's just so many different types of cannabis that are easy to use. And so when we see this rise in the general population, I think that we start to wonder about what happens when people get pregnant. And the presentations this morning have really covered very nicely prevalence. I know that Dr. Shea, who's speaking after me, is going to dive into that, so I won't spend too much time on that other than to say I think that the prevalence rates are all over the place, and some of this depends on the methods that they're using to detect prevalence, if it's self-report or if they're analyzing some kind of biomarker. Sometimes it's about the definition of prevalence, how many times they use it, how frequently they use it, over what period in the pregnancy. And so I think we could say that we don't really know how many people are using cannabis while they're pregnant. It's probably somewhere in like maybe a 6 to 8% range, but I will let Dr. Shea, who knows a lot more about this than I do, fill us in on the details on that one. We know even less about how many people are using cannabis while they are breastfeeding, although it's probably more than people who are using it in cannabis. We know the 2022 Canadian Cannabis survey saw about 4% of people reporting that they're using cannabis during pregnancy, and that increased to about 6% of people reporting that they used it while they were lactating. So we probably see an additional impact there. We've already seen quite a number of presentations about why people might not want to use cannabis while they're pregnant, and we heard from Dr. Green just recently about why people would want to use cannabis while they're pregnant. And I think that this is really the crux of what my research is about too. So there's a fair amount of literature on why people might want to use cannabis while they're pregnant or lactating. Often this is to treat conditions that they were using it for successfully before becoming pregnant. Sometimes it's used to treat conditions that arise during pregnancy. And the list of these conditions is very long. So people have reported that they've received therapeutic benefits from cannabis to control pain, anxiety, nausea, epileptic seizures, for skin and hair treatment, all kinds of different things. We also know that people are using cannabis during pregnancy as a form of harm reduction, which was covered nicely in the last presentation, and also to decrease the perceived negative impact of unmet physical or mental health needs, or sometimes as a way to stop using substances that are deemed to be more harmful in their pregnancy. In terms of why they might not want to use it, I think we've got lots of information about that this morning, so I'm not going to spend too much time on this, just to underline again that a lot of the evidence that we currently have is it's not well-controlled studies. We've got all of these confounding factors, socioeconomic status, other conditions or other substances that they're consuming, self-reported levels. We've got some of our better trials are quite old, and we know that the composition of cannabis has changed over time. So really a lot of uncertainty between the clinical outcomes that are associated with prenatal cannabis use. So for our presentation or our research program, where does this leave us? We know that the general population is using cannabis more frequently in the past. We can suspect that following other jurisdictions, this use in the general population will increase. We don't know how many of those people from the general population will continue to use cannabis after becoming pregnant, but we can anticipate this is probably also going to increase. We know, again, from that 2022 Canadian cannabis study that about half of 20 to 24-year-olds reporting using cannabis at least once in the last year. So as this group gets a bit older and starts entering their sort of most reproductive, productive years, probably we will see the use of cannabis during pregnancy also increase. On the same time, we know that people have real reasons that they want to use cannabis. This isn't always just about it's fun, it makes me feel good, and it's a good time, and that's why I want to do it. But lots of people perceive like really strong benefit from their cannabis use. And when the clinical evidence is so confusing and contradictory and equivocal about what the clinical outcomes associated with that prenatal cannabis use is, it makes it a very challenging decision for folks to make about whether and how to use cannabis while they're pregnant. We see some of this reflected in the clinical practice guidelines. So from the obstetricians and gynecologists, both in Canada and the US, and the American Academy of Pediatrics, we see this acknowledgement that the evidence here is not great, but in the absence of evidence of safety, we should encourage people to cease their use while they're pregnant or lactating. And this sort of follows the idea of the precautionary principle. The precautionary principle is that if we don't know that something is safe, it's better just to be careful and to not consume that substance. And for people who are using cannabis occasionally, this probably makes a ton of sense. Just stop using it, right? But for people who perceive a really strong and really important benefit to their cannabis use, all of a sudden this decision gets more complicated. And so this is really the focus of my research program, where I'm interested in how people make that decision about how and when to use cannabis, and how they interact with their healthcare providers, how they talk about this, how the clinicians counsel about this, and how people make that decision. I think that often the decision is not made together. This is really the pregnant person who's making a decision about what's right for them, perhaps with their partner or with other friends and family. So what we did this mirror image study where we examined the perspectives of both pregnant and lactating people and the perspectives of prenatal clinicians. We started with a systematic review in both groups, and then we did a primary qualitative study with each type of participant. So our systematic reviews are published, and I'm going to highlight just one finding that I think kind of sets the stage for some of our qualitative findings. So interestingly, this is a little diagram of the way that the papers we found on pregnant people's perspectives were organized. But we found that the most influential factor, so more than author discipline, legal status of cannabis in the country that it was conducted, the year it was conducted, the funding source, the most influential factor in the way that cannabis was described in these papers that we synthesized about pregnant people's perspectives about cannabis was how cannabis was grouped with other substances. So we found a body of papers which really just study cannabis on its own. a group of papers which grouped cannabis alongside alcohol and tobacco, another group of papers which grouped cannabis alongside illicit drugs, and often these weren't named specifically. It wasn't like, we're going to study people's perspectives of cannabis and heroin. It would just say, we're studying people's perspectives of illicit drugs or substance use or something like that, but cannabis was included. And a very small group of papers which grouped cannabis with herbal medications. And these were like so influential to how the researchers and how the participants talked about their perspectives on cannabis and on the substance. So in the group of 12 papers where they were talking about cannabis by itself, we heard a lot about the complex decision-making process that people go through to decide whether and how to modulate their cannabis use once becoming pregnant. There was a very clear description of why people want to use cannabis, so what their reasons or what their motivations are in pregnancy for using, a discussion of risks and benefits and how people weigh that, and a real clear expression about the uncertainty of the risk of consuming cannabis while pregnant, and a desire for more clear and credible information about what those risks might be. In contrast, when the studies studied cannabis alongside either alcohol and tobacco or, sort of more generally illicit drug substances, we didn't hear about the sort of decision-making process, about a perception of benefits, how people went through this. Instead, we heard all about strategies for cessation, barriers to cessation, how we're going to get people to stop, why they can't stop, like a real focus on not using whatever the substance is. There was a lot of discussion about the legal or the carceral implications of cannabis use, and this is where we get into some of the themes from the last presentation about surveillance, legal system involvement, and a lot of fear and a lot of stigma around that. These papers tended not to frame cannabis use during pregnancy as a decision that somebody needs to make, but rather as a circumstance that somebody needs to extricate themselves from and needs resources to extricate themselves from. We also found this issue of comparator groups to be relevant to our review of clinician perspectives about cannabis use. And in that systematic review, we put together a model of how clinician awareness of cannabis use, which sometimes came because they screened for cannabis use, they asked about it, and sometimes came because patients spontaneously disclosed, but how their awareness of cannabis use impacted their response. And one of the findings here was that studies which included cannabis as one of many substances that they were studying were likely to describe clinicians as encouraging cessation than studies which addressed clinician responses only to cannabis. The multi-substance studies were likely to offer more suggestions for improvement to current systems to better address substance use, rehabilitation, that kind of stuff. The studies that looked at only cannabis were more likely to describe clinician perspectives that they themselves lack knowledge and training to counsel about cannabis and to help their patients make these decisions. They typically evaluated themselves as having low confidence in their ability to have these conversations. When they did counsel, many said that they just recommended abstaining from cannabis use, and there was very little recognition of the many reasons that patients might want to use cannabis, and an over-reliance on counseling which focused on the legal implications of use. So I think this triangulates very nicely with the finding from the last presentation that sometimes patients are afraid to bring it up to their care providers because they are anticipating that they will receive judgment and stigma and stop using this and why are you using it, and then afraid that that will result in more surveillance, a call to Children's Aid Society, that kind of thing. In terms of what our systematic review told us about why people might use cannabis in pregnancy or lactation, this was really only discussed in the group of papers that examined cannabis alone. It was like kind of shockingly absent from the other papers because people also have reasons that they want to use alcohol or they want to use tobacco or they want to use methamphetamines or whatever it is that their experience is. But those papers didn't tend to address the reasons why, right? But in those 12 papers that were just about cannabis, they gave such a long list of the reasons that people were endorsing for consuming cannabis. And I don't know, I have like a little list of this in my notes here, so I could give it to you. Anxiety, depression, bipolar disorder, PTSD, insomnia, anemia, chronic pain, like over and over and over again. But I think that the point is that people perceive important benefit from cannabis. These studies also talked about people wanting to use cannabis for pleasure, to manage stress, and to improve mood. So it's not just sort of clinical diagnoses that they're perceiving benefit from. And when we start to think about why a pregnant person might want to use cannabis, then we can start to recognize her autonomy and her position as a decision maker in this encounter. When we approach this question from a lens of how can we persuade people to stop using cannabis, then we maybe stop seeing the nuances of that decision-making process and how the different parts of their life might influence their consideration of why and how much and what form to use cannabis. And so a really important part in our work was positioning the pregnant person as an autonomous decision maker who's embedded within a community, who's embedded within sort of a social environment that influences the way that they make decisions. So here we are back to what we did, and now I'm going to share some of the findings from our qualitative study of pregnant and lactating people. So in this study, our central question was how people decide whether or not to use cannabis when pregnant and lactating. Why do they want to use it? How do they make that decision? And how do they perceive the risk of cannabis? And what, if anything, do they do to try to mitigate that risk? So we interviewed 52 people. We used the qualitative methodology of qualitative description, and all of our participants were regular cannabis users before they became pregnant, but we purposefully sought folks who went on different trajectories after finding out that they were pregnant. So we wanted to find some people who stopped using cannabis, who continued, who altered their use so that we could understand the decision-making pathways in all of these cases. So our sample consisted of 51 people who identified as women and 1 non-binary person. They were mostly white, about the same proportion of Canadians who are white. 40% talked about their first pregnancy, 60% were speaking about they had other children and they often drew in experiences from other pregnancies. They lived in all Canadian provinces in 1 territory, and they had a range of ages and education levels that are pretty reflective of the reproductive population. So in our first study, and this was published in the Canadian Medical Association Journal at the end of December 2021, we outlined the reasons for people using cannabis during the pre-pregnancy, pregnancy, and postpartum periods, and we talk about how those reasons changed. So we identified in this analysis 3 kind of categories of reasons that people want to use cannabis during the perinatal period. The first category is sensation seeking, which is like recreational for fun and enjoyment. The second category is symptom management, both for chronic conditions and also for conditions associated with pregnancy. This could be self-directed. It could be on the advice of a clinician. For most people who were seeking the management of a physician for their cannabis use, that tended to happen before they became pregnant, and then they just kind of continued what they were doing after they became pregnant. We didn't have too many examples of people who were receiving medical management for their cannabis use while pregnant. The third category was for people who were coping with the unpleasant but non-pathologized experiences of life. So we called that coping, and this was about sleep quality, stress, low levels of anxiety, that kind of thing. So I'm going to show you how these reasons for use that they endorsed changed over pregnancy, but I'm just going to orient you to this diagram first. So if you're colorblind, I apologize because this is going to be hard to understand. It really relies on a bit of color theory here. So most of our participants gave multiple reasons for using cannabis, and in the red circle represents coping, yellow, also a primary color, sensation seeking, blue is symptom management. And then the secondary colors in the overlap are representative of people who endorsed both of those reasons. So the brown 7 in the middle is people who endorsed all 3 reasons. The 7 in the green is people who endorsed both sensation seeking and symptom management. So you can see before they became pregnant, there's, like roughly equal proportions in each of these circles. And this is qualitative research. It's not a representative sample. We're not trying to make conclusions in that way. We're just sort of looking at patterns here, right? When they became pregnant, all of the use shifted down to symptom management. We had one person who said, oh yeah, I used it for sensation seeking, but I just wanted to say goodbye before I gave it up because I was pregnant. So like really overwhelmingly, our participants were like, when I was pregnant, I just used it for this therapeutic benefit that I experience. Oh, and it also helped me cope with my sleep, or also it makes me feel nice. So like really symptom management was the primary reason. After they gave birth, for those who were breastfeeding, it kind of went back to the pre-pregnancy distribution. Not exactly, but quite similar. And so I think one thing that we're seeing here is that people really understand that when they're pregnant, there's all kinds of things that you shouldn't be consuming, and the pregnancy or the fetus is vulnerable to the whatever the mom is consuming. But then maybe a little bit of a less of a recognition of that after they give birth. And over again, we heard people talk about the alcohol use guidelines during breastfeeding and kind of transfer those to cannabis. So there's all kinds of like charts about how many drinks you can have before you can breastfeed, or how long you need to wait, or all this kind of stuff for breastfeeding. And we had a number of participants who just kind of did that only with cannabis. So like, I'll just have a little bit and then I'll wait 4 hours and it will be fine. They really didn't understand the like very different metabolic pathways of cannabis in breast milk. So I think we heard a little bit about that research before. Would love to see that translated to lay people, because I think it's a real knowledge gap here. When we looked for patterns between how the reasons of use for a particular participant kind of tracked over these 3 different periods, we saw a couple of patterns. We saw that people who were using just for the purpose of sensation seeking before they became pregnant were very likely just to stop altogether. I think that intuitively makes sense, and a lot of our clinical guidelines are kind of built on this assumption. We also saw a pattern of people who were using cannabis to manage symptoms of a chronic condition that continued during pregnancy, continued to use cannabis to manage that chronic condition while they were pregnant. Also kind of intuitive. But overwhelmingly, like other than those 2 patterns, the reasons for use changed, and it was not consistent. So we had some people who said that they only used for sensation-seeking purposes before they became pregnant, but then after they became pregnant, all of a sudden now it was symptom management for nausea and vomiting. Or people who were managing the symptoms of their chronic condition before they became pregnant, who would then cease during pregnancy because they didn't want to expose their fetus to cannabis. And so I guess I would say that the most prevalent pattern was that there was no pattern. Like, people were really making their own individual decisions here. So what did we learn from this? What did we conclude? I think that we learned that people really perceive cannabis to be very helpful for like a wide variety of things. And it was sort of striking how different the reasons that these participants gave us for why they were consuming cannabis, how different these reasons were from the comprehensive marijuana motives questionnaire, which is kind of the go-to cannabis reasoning instrument that exists. There was really only congruence in 3 domains: enjoyment, coping, and sleep. Everything else didn't really apply to this particular population. The reasons that our participants gave for why they wanted to use cannabis most closely matched the reasons that were identified in studies of medical cannabis use. And I think that this also sort of speaks to the deliberation and the careful decision-making that many pregnant and lactating people undergo when they're deciding whether or not they want to continue their cannabis use at the different perinatal stages. And this also opened up for us a whole bunch of additional questions about what information they were using to make these decisions. So in our second analysis, we explored the information needs of pregnant and lactating people as they made this decision whether or not to use cannabis. And we aim to describe the modes and the sources of their information seeking and their satisfaction with the information that they did find. So over and over again, we heard people spending a ton of time and energy trying to find information to make this decision about cannabis use. They were very deliberate in their searches for information. This wasn't one of those situations where they just kind of like used the information that came to them without searching for it. Found information is what the information scholars would call this, but they were like very deliberate in seeking out this information. They often sought information online or through known people like family or friends. Strikingly, and very unusual in pregnancy, clinicians were not seen as a comfortable or an informative source of information. And that is different from like almost every other topic I know about in pregnancy, where typically people want to talk to their doctors or their midwives. These are the people that they want to get information about diet changes or tobacco use or exercise or prenatal testing or whatever other decisions they have to make. And I think probably, again, we can guess why from the previous conversations, because they're afraid that they're going to get judgment, that they're going to get, sort of taken on this conveyor belt into the state surveillance child welfare system. And also another bit is that they recognize from the online searching that they've done that there's not a lot of great information out there to be given. So also sort of unusual in this kind of pregnancy information seeking field is that these participants were very well versed in the scientific and clinical literature. And we had people over and over again tell us, well, we don't really know, right? Like the scientific literature, the evidence isn't there, like it's just not cut up. Like it's not that the information's out there and I just can't get it. It doesn't exist, which to me was like a pretty good synopsis of the state of the clinical literature. And that was kind of surprising. But they were really many people recognized the underdeveloped state of research evidence. And so noting that the thing that they really wanted to know about was risk. This was the topic that most people were looking for, and this was also the topic that people were sort of least satisfied with. They didn't feel like they were able to find good information about risk. So this led us to our third analysis, which we're just working on the revisions right now. So this is, secret, I guess. But what we heard, again, around the topic of risk and how they understood risk was that overwhelmingly these participants understood there to be some degree of risk to themselves, to their fetus, to their future child by consuming cannabis while they were pregnant. But beyond saying, yes, I think that there's probably some kind of risk to this, they were unable to articulate what those specific risks might be. However, the perception that there was some kind of risk galvanized them to take action to mitigate that risk. And sometimes the action that they took was just ceasing use, stopping. But often it was these sort of very complex, deliberate, well-reasoned behavioral strategies. And as someone who's interested in how folks make decisions about health things and then translate that into action, this was very, very fascinating to me. We heard all kinds of different strategies about how they changed the form that they were using, the dose, the timing, how they brought in other support systems. So for example, making sure that their spouse was available to care for the kids when they were consuming cannabis, when they were under the influence, trying to time feedings with cannabis consumption, very, very careful and deliberate, and a lot of energy put into mitigating these risks. And I think it was interesting here was that there wasn't a pattern, again, no patterns, of activities that they were doing. And we kind of saw people's idiosyncratic reasoning in all kinds of different directions. So some people stopped smoking cannabis and started using oils or edibles because they reasoned that the inhalation of the smoke would be bad for the baby, because often they'd read a lot about tobacco use. They kind of translated that finding into smoking. Whereas other people said, you know what, I'm not going to do oils, I'm not going to do edibles, I'm going to just stick to smoke because I can calibrate my dose better. I can just have a little bit. I know that it's not going to affect me too much. I can, do it slowly so that I can just have the absolute minimum amount that I need to get the benefit that I'm trying to get. And so I think that this finding, it's kind of back to this isn't just people being ignorant or people not caring or not thinking that there's a risk. It's these pregnant people, they care, they don't want to expose their fetus to risk, but they perceive this benefit that they want to keep experiencing. And so they're trying to reduce the harm in whatever ways they can. And they also recognize that there's no guidance for them on this, right? So unlike these wonderful charts about alcohol consumption of breastfeeding, there's very little public health guidance about what one could do to lower the risk, to reduce the harm to their breastfeeding infant or to their in utero pregnancy while still consuming cannabis. So kind of all to conclude, or all in all, we've learned a few things. We've learned that since legalization, cannabis is readily available, it's less stigmatized, and people are learning to find it helpful. Like, I think that this is really probably the key pathway with legalization, is that as people are exposed to it before they become pregnant, they start liking it. It's helping them with things that they need to be helped with. And then they become pregnant, and they're in sort of this quandary about what they're going to do now that they become pregnant. And overwhelmingly, for the 52 people that we spoke to, perinatal cannabis use is deliberate. It's thoughtful decision that involves a very careful weighing of risks and benefits with the best information that they can find. But they also appreciate that that information, the best that they can find, is not complete, and it's not comprehensive, and it's not sufficient to help them make the type of decisions that they want to be making. This informed decision-making process is stymied by a lack of information, both sort of in the research, clinical evidence, but also from clinicians, and a reluctance to engage with their clinicians about this topic. And that really, I think what we're hearing from these participants is that they desperately want more clinical research of exactly the type that you're all doing, that we heard about this morning, to produce the kind of clear public health messaging and guidance that could guide their decision-making. Yeah, that's it.
Hi, just loved your talk. I have two questions. The first one, I think, though, you answered. I was going to ask you, based on looking at all of the patients you recruited, looked at, is there a prevalence for a particular route of cannabis use in pregnancy? Is it oral? Is it inhalation? But it sounds like it's a mixed bag. Is that
I think
correct?
It's a mixed bag. I think that people are likely to want to continue the form they were using before they became pregnant. Like, it just, there was a lot of self-management of these conditions. Sometimes it was with a clinician, but they had, by the time they got pregnant, they had calibrated their dose and their timing and their form to like manage whatever it is they were trying to manage, or to enjoy the benefits that they wanted to enjoy. And then when they became pregnant, the decision was first like stop or continue, but then also, if continue, how to adapt. And a lot of people wanted to continue to do the same thing that they were doing before, but we did see adaptations, especially around decreasing the amount. Yeah.
And sorry, just to follow up, I'm very curious to know if in the conversations, if the idea came up that, oh, I should be taking CBD, cannabidiol, yes. This idea that CBD is not only safe, but I actually should take it, as I said earlier, to boost fetal outcomes. Did that come up in your conversations?
Like, not to take it to boost fetal outcomes. We didn't hear that. But I was really excited to see your presentation, because over and over again, we heard, I'm going to do CBD because if I'm not getting high, it's no problem. Like, a real perception that it's the THC, that it's whatever that makes them feel high that they need to avoid. So lots of people switching to a CBD only product, eliminating the THC and thinking, I'm good, this is no problem. And we had more than one participant that we would talk to about, how, like, what was your cannabis use like before you became pregnant? Okay. And then, walk me through how that changed. And then halfway through the conversation, they'd be like, oh, but I forgot to tell you that I take CBD oil every night to help me sleep. But like, I stopped smoking marijuana, but like, this is just CBD oil, so it's okay, right? So it's like almost, in many people's mind, I think, a different substance. Like, we had to probe quite specifically, are you using any topical oils? Are you using any CBD teas? Are you, like, all of these sort of bits that sometimes would escape their conscious recollection, because they really would think that our study was about smoking weed and getting high. Yeah.
Hi, thank you. Really good presentation. My question is, when you're talking about the different ways that women were talking about lowering their risk while still using cannabis, I'm wondering, did it ever come up, women talking about shifting where they're actually sourcing their cannabis from maybe more black market use to legalized means that you may be able to better control potency and more information on things like that?
Yes, definitely. Great question. So we heard sort of two different routes that people judged to be safer or to lower risk. One was growing it themselves, or getting it from somebody who was growing it themselves, where they like really knew that this was not, for instance, being cut on a table where fentanyl had just been cut a few minutes ago. And then the other was through the government, through the legalized stores. And definitely, like, I was going to say a comfort with this, but I don't think it was necessarily a comfort, but just sort of a reassurance that there was no cross-contamination, that there weren't other substances here, that they knew what they were consuming, and they could be confident that there wasn't kind of anything else mixed up in that. Yeah.
Great talk, Meredith. Thank you very much for that. I'm just wondering, this might be an unanswerable question, but...
Love those. Those are my favorite.
So you talked about sort of the mistrust in the medical community. People are turning to the internet. Has there been any research done on what might be the best way to get information across to individuals?
Yes, there is a whole field of this. I unfortunately am not an expert in this field, so I won't be able to answer your excellent question in the way that it should be answered. But yeah, there's lots of great lots of great science about how to translate knowledge to pregnant people and where they go and how to make this available. I think that what we're learning from this study was that some of our typically relied upon paths for communicating information to pregnant people, clinicians, group counseling, pamphlets and other materials in doctors' offices, probably don't work with this. Probably what we need to do is some university, hospital, branded science, credible websites that people can find and read on their own that have links to the studies, but also a translation into lay information. Because folks, many of them were really savvy about, okay, I know that I can go to this Mayo Clinic site because I can trust that. I found this other Cannamamas thing. People are talking about their personal experience. It's kind of nice to hear about personal experience, but that's not what I'm looking for. I want something that I can trust. So lots of people engaging with that personal experience sources and talking with people in community, but also not seeing that as like the definitive, credible information about clinical outcomes and risk and harm and that kind of stuff, and being pretty great at identifying sources that they could trust that would be more credible. So I think for those of you who are working on these really important questions, that even on your lab website, like a page about here's our study, we published it in this journal, but like what do you need to know? You need to know that CBD is like an active substance that you should be concerned about. That just because you're consuming a cannabis product without THC doesn't mean it's without risk. Like I think that would be people will find it. Yeah.
As a plug for the CMCR, we are going to be rolling out a new KT strategy in the fall. So hopefully some of that information will be on our website.
Great. Yeah.
One last question from the online chat from Gail Delaney. The default position we as physicians are taught is not to prescribe pretty much anything during pregnancy unless there is research, clinical data supporting use of the substance safely. If a physician was not to warn a patient that there is no data saying it is safe and a newborn has medical issues, there is a bit of fear. I believe that the MD might be sued. Did you get any feedback from clinicians, MDs, midwives, etc., on this issue?
Yes, definitely. And this is the project that we didn't talk about, but I think Dr. Delaney has very nicely described what we heard from so many of our clinician participants, which was, there's not evidence. I can't tell them to do things that we don't know are safe. But maybe there's a middle ground here with opening an open, non-judgmental conversation about why are you using this? What are the benefits do you perceive? Okay, do you know that there's not evidence that this is safe, that there could be a risk? What are the other options that might help you receive some of those benefits that we do know are safe? Oh, you've tried that and it doesn't work. Oh, you've tried that and it doesn't work. Okay, well, I can't tell you that it's okay or it's safe. But I think there probably is a conversation that could be had there that's not a prescription, that's not a recommendation, that's not an endorsement, but sort of an exploration of other options in a way that doesn't leave the person exiting your office with the therapeutic alliance shattered and feeling like I can never talk to any healthcare provider about my needs and about what I want to do again. Okay, thank you.